Good evening and welcome to the NSWOCC Perfuse MedTech and Canadian Home Care Association webinar series, Wound Care Strategies for Keeping Patients in the Home and in the Community. This is the first webinar of a 6-part webinar series, and for more information on those series, you can go to nswac.ca. This evening, Dr. Michael Stacey is our guest speaker, and he will present on improving blood flow and microcirculation in the lower limb. And I'd like to take just a few moments to introduce Dr. Stacey, who has quite an impressive CV. He's a vascular surgeon. He came to Canada from Australia in 2014 as the surgeon-in-chief at Hamilton Health Sciences and professor in the Department of Surgery at McMaster University. He completed his medical degree at the University of Western Australia, is a fellow of the Royal Australian College of Surgeons, and is licensed with the College of Physicians and Surgeons in Ontario. He spent 2 years working at St. Thomas Hospital in London, United Kingdom, where he conducted research for his Doctor of Surgery degree, which is a PhD equivalent. He took on the role of Chief Medical Executive and Executive Vice President Academic at Hamilton Health Sciences in 2018 until mid-2023, and he currently continues his clinical work in vascular surgery and is a consultant for hospitals and biomedical companies in the area of clinical practice, research, and physician leadership. As well as his practice in vascular surgery of more than 30 years, Dr. Stacey has established an active research program in wound healing in both Australia and Canada, was the first president of the Australian Wound Management Association, now Wounds Australia, and the founding chair of the World Union of Wound Healing Societies. He previously established a multidisciplinary diabetic foot clinic and a venous leg ulcer clinic in Australia, and is in the process of establishing a similar clinic at Hamilton Health Sciences. As well as his clinical interests, Michael is also an artist, using mainly oil paint as his medium, and he is a poet. He has published poems in multiple anthologies and periodicals, and you can see his poetry on Instagram at Michael C. Stacey, artist and poet. So I would now like to turn things over to Dr. Michael Stacey. And at the end of the presentation, we will have time for questions and answers. So please put your questions in the Q&A box at the bottom of the screen, and we'll be sure to have some dialogue. I'll turn it over to you, Dr. Stacey.
Great. Thanks very much, Kathy, and thanks for that introduction, and welcome everyone to this session. So today I'll be talking about improving blood flow and microcirculation in the lower limb. And it's an interesting topic because it actually speaks to some of the commonality of problems that many of the lower limb wounds that we all see and have to deal with. Oops, let's check if this is advancing. Yeah. Is that advancing okay, Kathy? Just checking that that's all right.
Yes. Yes.
Great. Just very briefly, conflicts of interest, just put them up here. I do have some current active consultancies with companies as there. I'm a board member of Woundpedia, and have also previously had consultancies with a number of different companies in various elements related to research in particular. So for this talk today, what I'm going to talk about is the blood flow, which is a critical element at improving and expediting wound healing, particularly in different types of lower limb ulcers. So look at the strategies that we have to improve blood flow in the different types of wounds, and then what of those strategies may be helpful to try and keep patients in their home or in the community where that's possible or feasible. So as you know, the common causes of leg ulcers that we see are either peripheral arterial disease, there can be diabetic foot ulcers, there can be venous leg ulcers, and at times we have patients with combinations of these factors. These all together account for greater than 95% of all lower limb chronic wounds. There's a long list of other potential causes, But the commonality in all of these, even though the underlying cause is a little bit different, is there is a commonality in the problem with the microcirculation. And what we do know of that, if we think about the different types of wounds, with peripheral arterial disease or disease of the arteries that may be an inflammatory disorder such as vasculitis, we do know that there is a reduced blood supply and reduced microcirculation due to either that damage or that change in the large or the small vessels. And this has been demonstrated many times over the years by different measurement methods, obviously ankle brachial pressure indices, but using transcutaneous oxygen measurements or using things such as laser Doppler. And improvement can be demonstrated when we address and treat these particular deficits. In patients with diabetic foot ulcers, the etiology of the impaired microcirculation is probably two major factors. One is the ongoing pressure that occurs because of primarily the patient's neuropathy. So they can't really feel that they've got continued pressure on particular parts of the foot. And it's this continued pressure that leads to compression of the blood vessels and reduction in the circulation. In addition to that, they may also have problems in their arteries, either larger vessels, and a lot of them also have microvascular problems as well, simply because of the impact of diabetes on the small vessels. And similarly with venous disease, maybe people don't quite recognize this as much, but venous ulcers, which are due primarily to a problem in the way the veins are functioning in the leg, either due to deep vein thromboses or due to incompetence in the deep or superficial veins, they end up with this problem that's called ambulatory venous hypertension, so an increased venous pressure when they're walking. And the resultant impact of that is it impacts the microcirculation. And there's been a lot of theories as to how it does that, and I'll touch on that during this talk. But there can be things such as arteriovenous shunting, changes in the capillary beds, even to some extent clogging of the capillary beds, or deposition of protein around some of the capillaries, resulting in this reduced microcirculation. So the point and the interesting thing when you think about it in this way is that even though the actual cause of the problem is a little bit different in each of these types of ulcers, the end impact is that it's that impaired circulation in the tissue that leads both to ulcer formation, but also to the challenges with healing the wounds. And with these types of chronic wounds, there is a commonality in the underlying healing problem. There have been a lot of studies that have demonstrated that one of the underlying issues is an increased inflammatory state or response within the tissues. And this has been measured in many different studies by the elevated levels of inflammatory cytokines, which results in an increase in inflammatory cells. And these types of chronic wounds enter what we call a state of chronic inflammation. And the key hallmark of chronic inflammation is that you've got two processes going on at the same time. One is you've still got continued tissue damage, be it from the impaired circulation, be it from the pressure that impairs the circulation, be it from the increased ambulatory venous pressure in venous disease. So they result in problems in the microcirculation, and if not corrected, continues to damage the tissue. And at the same time, you have this ongoing attempt at repair. And this is what differentiates chronic wounds from acute wounds. With an acute wound, you have an episode of injury that is short-lived. That injurious episode finishes, and then the wound can go into a repair process. And that's why acute wounds, unless there's some other underlying systemic problem, will go on and heal well due to the body's natural processes. Whereas chronic wounds enter this chronic inflammatory state that actually delays and impairs the healing. So what can we do to improve flow in leg ulceration? So the approaches are a little bit different in each of these types of wounds, and that's what I'll focus on today. So talking about what are our options with arterial disease, what are our options with diabetic foot ulcers, and what are our options with venous leg ulcers. So if we start with the arterial disease and ulcers due to arterial disease, where we have larger vessel problems, either stenosis or occlusions, then traditionally the way we've dealt with this is to look at some form of arterial reconstruction, whether that's surgical or whether it's endovascular with angioplasty. And by doing that, we can then improve the tissue microcirculation. There are some newer options, which I'll talk about later in the talk, that actually do provide us that opportunity to improve microcirculation. Their application for the present is particularly in those patients for whom there isn't any other intervention option. So when we talk about patients with peripheral arterial disease, then so what can we do to help improve that blood flow and microcirculation? So before we even think about arterial reconstruction, we think about what are the other simple options that we have. And what's the evidence that these can help with the microcirculation? So really some of the most effective methods we have are smoking cessation, which does in many patients help improve the microcirculation. And often if they have claudication, their claudication distance can improve significantly if they stop smoking. And in part it's because of the vasospastic effect of some of the residual elements of the smoke that is being inhaled. Exercise is also another very effective way at improving the microcirculation in patients with arterial disease. Again, this is more in patients who don't have that very extreme arterial disease with ischemic rest pain. And then finally, revascularization, which is very effective. Weight loss we use for other reasons, more for helping to control systemic factors. It doesn't do anything directly to the underlying microcirculation in the legs. And there have been other drugs that have been used, vasodilators, which generally are not that effective at helping to improve the peripheral microcirculation. So when we come to our interventions that as vascular surgeons we use, in this day and age, our go-to or our first choice, if it's possible, is some form of percutaneous transluminal angioplasty. And this is what a modern operating room looks like for patients who have peripheral artery disease. So we have this, what's often called a hybrid suite. So we've got an angiography set up in the operating room, so we can do combination of open and endovascular procedures as is needed. In these cases, if it's all endovascular, we usually just puncture the arteries in the femoral arteries, sometimes in the arms. By placing wires and catheters, we can then go about treating the narrow segments or the blocked segments. So the simple thing that we do in these instances is what's called a balloon angioplasty. So this is where you'll see in this image here, there's an atherosclerotic plaque here, which had been causing some narrowing. We cross that with a guide wire and then can place a balloon across that plaque, and then we inflate the balloon. And what it does is it compresses the atheroma into the wall of the artery. And if you look at these images on the right, the first one is pre-angioplasty, and you see this lesion here just as it's crossing the femur to begin with. And after it's been dilated, it actually has improved quite significantly. Not all lesions improve to that extent, and you see this one here. After angioplasty, there's some improvement, but you can see there's what we call a dissection here. So you've got a couple of lumens sort of going down through there. So in this instance, we would usually then add a stent to try and keep that artery fully open and compress any of this material into the artery walls. And this is just showing you what the stent is. Stent is really effectively a a metal structure. It can be either made of things like nitinol or steel. It's an expandable stent. Some of these are self-expanding, some we expand with a balloon, but basically we place them across the lesion. They're expanded. And if you look to the right, this is just showing you a renal artery. The same principle applies to arteries more distally. Here's a significant narrowing here. Here's the catheter just lining up. A guide wire is put across it. And this side, you can see there's the guide wire, the stent's being delivered and expanded. And now you can see a very open artery there. And that's the type of result we see with angioplasty and stenting. And we use this particularly in the iliac arteries, in the superficial femoral artery, in the thigh, and in the tibial vessels. They're the common sites where we, for the peripheral arteries, where we use both angioplasty and stenting. The other method, obviously the traditional method, has been to do some form of bypass operation, and where the disease is predominantly in the iliac arteries or the aorta. Traditionally, what we've done in this sort of situation is an aortofemoral bypass, where we sew a graft onto the aorta and then sew the lower limbs down onto the common femoral arteries in the groins. Another option we have for treating a lesion like this is to angioplasty the site where there is a narrowing, as in this case, and then do a femorofemoral bypass. So this allows blood to come down that right iliac artery, down into the right leg, and this allows it to cross it over into the left leg. In general, we usually can't get across significant occlusions in the iliac arteries, and we don't like to push these too much because there is a risk of rupturing these if the wires happen to go through the wall of the artery. And in a big vessel like the iliac artery or the aorta, that creates a fairly significant emergent situation. The other type of option we have, you may have heard of or seen, is an axillofemoral bypass graft. So this is where, if for any reason we can't do something in the abdomen, then we take a bypass from the axillary artery just under the clavicle, run that down the side of the trunk into the femoral artery on one side and across to the other. A good operation for getting out of trouble, but they do have problems in terms of patency long term. And then the other thing that we use quite a bit in open procedures is what's often called an infrainguinal bypass, so below the inguinal ligament. So this is a bypass that generally goes from the common femoral artery, can go down to the popliteal artery above or below the knee, or into the tibial vessels. In this case, it's onto the perineal artery, and that can go right down to the arteries at the ankle of the foot. In these instances, we mostly use a vein, as this gives the best long-term patency. So we use the patient's great saphenous vein. If that's not suitable, we can use a synthetic graft. The patency is still pretty good, but not quite as good as with a native greater saphenous vein. And sometimes we use a combination of a synthetic graft and some vein if there's a small amount of vein available. This is just showing you what that might look like. So when you harvest this greater saphenous vein, there's an incision right down the leg. These days, we mostly do this by leaving some skin bridges. So we dissect the artery at the top, we dissect the artery at the bottom, we dissect the greater saphenous vein and ligate the branches. Leaving skin bridges, we can actually find the branches underneath the skin bridge. And the skin bridges help to reduce wound complications and speed up wound healing in these instances. And then there's one other procedure that we use, which is for a particular type of arterial problem, and that's called a femoral endarterectomy. So this is where we have very localized disease in the common femoral artery, where there's atheroma, but the arteries above and the arteries below are generally in pretty good condition. And so in these instances, we do an open operation where we open up that artery, remove or endarterectomize that atheroma, and then close the artery up with a patch of synthetic material or bovine pericardium, which then helps to keep the artery open and helps to prevent further restenosis. So we move on then to diabetic foot ulcers. So what are our options here at improving blood flow and circulation? So As I mentioned before, the major underlying problem is the local pressure. So what we can do is to try and improve or reduce that local pressure. If they do have arterial disease, then we can deal with that if it's suitable for intervention. And then, as I mentioned, there are other options we have, which I'll touch on later, that we can improve microcirculation if these other options are not working appropriately. When we have a patient, with a diabetic foot ulcer, what we do want to know is, do they have arterial disease? Because if they do, and it's correctable, and they've got an ulcer that is a significant lesion, then in most cases, we would definitely look at doing something to try and improve that circulation. Sometimes they'll heal if the arterial disease is not too severe, but in many cases, they do require some form of reconstruction. We obviously also need to deal with sepsis if it is present, because that can result in continued destruction of tissue because of the damage that the infection causes both to the microcirculation and the tissue. So reducing infection and eradicating it helps to improve the circulation and the viability of the tissue. So if we have just someone with an uncomplicated ulcer, and by that I mean there's no evidence of any arterial disease, so they're primarily an ulcer due to a neuropathy. So the things that we do in this circumstance to try and reduce the pressure, firstly, we need to debride any callus or non-viable tissue, because the callus really acts as a hard or rigid object in the skin that with walking and pressure on it, continues to damage the underlying skin. We obviously want to then apply dressings to that, but the other key thing is to relieve that pressure. And there are two types of pressure that we have to consider. There is the direct pressure and the shearing pressure. So direct pressure occurs, as in this lesion here, where you can see, with walking on it, there's pressure directly impacting that wound. But the shearing pressure tends to occur if there is more movement. So what's happening there is this movement of the soft tissues over the underlying bony structures. And the way you can detect that is by looking at the wound, you can see either clefts or undermining of the tissue. And what that's telling you is that the tissues are moving, they're not able to adhere appropriately. So where there is direct pressure, we look at some form of footwear. We commonly use a Darko shoe or some variation of this, with some form of pressure offloading within it. And I'll come on to that a little bit later. But there are ways of reducing the pressure in an area like this, where you have an insole, where you remove some component that takes the pressure off that. And there are shoes that have forefoot or heel relieving segments, and I'll touch on that a bit later. And the other element is, if you've got shearing pressure, then you really want to minimize the movement. And there it really requires some form of immobilization of the foot and the ankle. So this might be an ankle foot orthosis, so a splint. It might be a cam walker. Crow boot does the same thing, although that is more specifically for patients with Charcot's. I'll show you that in a minute. Or things like total contact casting, which again, what that really does helps to reduce the movement, and you can also adjust it so you reduce direct pressure as well. So this is just showing you, this is what's sometimes called a cam walker or a controlled ankle movement walker. So it's really like a removable splint, basically. And what it does is it stops movement at the ankle, it limits movement at the forefoot. So if you've got undermining, as you do in this heel, or if you have undermining in other areas, we commonly see that around the first MTP joint, sometimes the fifth one. Then reducing that movement is critical to try and improve the circulation and get these wounds to heal. And this is just showing you, this patient has a Charcot's deformity in the foot. You can tell by this being having lost its longitudinal arch, it's lost the transverse arch, but there is prominence here where the bones, small bones, have become disrupted, and they've effectively areas that are bearing weight when they normally shouldn't, and this results in damage to the tissue. As I mentioned with sepsis, we obviously do want to control that because sepsis impedes the blood flow, damages the cells themselves, and can result in that continued injury and delayed healing. Important things to remember in patients who have sepsis is they don't always have an open wound. Sometimes what we see is they've got a callus, but there's inflammation around. And this is why debriding the callus is important, because you'll often find an ulcer underneath with a lot of purulent material within it. They don't always have ischemia, so sometimes their large vessels can be in good condition, although they have a degree of necrosis. And this can happen because there's small vessel disease, and with infection, that impedes circulation, results in tissue loss. And obviously, we've got to work out if there's underlying osteomyelitis, because we have to deal with that. And also, we need to be aware that sepsis can be rapidly progressive, particularly if there are synergistic organisms that are working together, basically causing more damage than often one single organism alone. And just showing you in this case, there is this inflammation. When you take your X-ray, what you find here is that these metatarsal heads are intact going across, but you don't see one here. You also see the base of these phalanges. You don't see it here. So this patient's got significant underlying osteomyelitis. And the principles of treating the sepsis, obviously, we want to base it on swabs. We start off with some broad spectrum antibiotic. And once we've got some cultures back and the sensitivities, we can refine the antibiotics that we use. Clearly, if there is infection, we also want to debride any necrotic tissue, because that only acts as a culture medium for bacteria. And that may include extending down to the joint or even bone. If we have to do that, we leave the wounds open, and at times we need to amputate if it's a completely necrotic toe in particular. Then obviously we monitor that with looking at the inflammatory markers, particularly C-reactive protein. The other thing when it comes to peripheral artery disease in diabetes, so we have to just be aware that it's not always as obvious as perhaps you might think. And when we do ankle brachial indices, these can be misleading, particularly if the ratio is greater than 1.4. The vessels are often calcified, particularly in diabetic patients. And the disease can be at different levels, but patients with diabetes particularly have more evidence of atherosclerosis in the tibial vessels, which themselves can be more challenging to deal with from an intervention and reconstruction point of view. As I mentioned, we do look at some form of surgery, which is debridement if there's sepsis, or revascularization if there is a disease that can be actively dealt with. And this is just an example showing you, this patient had some infection, necrotic toe was removed, but you can see there's ongoing necrosis, there's ongoing infection, and this patient had significant arterial disease and clearly needed revascularization. So what about venous leg ulcers? So, people often think of venous leg ulcers and they think you're putting compression on to help reduce the swelling, etc. But venous leg ulcers, we need to understand the underlying pathophysiology here. They're caused by a problem in the underlying venous structures in the leg that return the leg up, the veins and the blood up the leg. And the problem is they've got an elevated ambulatory venous pressure. So the things that we can help to improve the circulation is compression, which I think we all know that. But compression, some people think compression just helps edema, but what compression really does, it actually helps the venous return. And if you can improve the venous return, you can help improve the microcirculation. Exercise is also very important in patients with venous leg ulceration. And then, as I mentioned, as I'll touch on later, we've got other options at improving that microcirculation. So just to show you, there are ways we can measure the abnormality in the venous function. when we use things like photoplethysmography, we're measuring more rapid refilling than we normally see. But another method that we use is either using venous pressures, but there are now more non-invasive methods. So this is a thing called an air plethysmography, and this can measure the refilling time, but also the venous volume. So how much blood can be pumped out of the leg. And that's determined by how well the veins are functioning. And this can all be improved by compression and by exercise. And I'll just show you very briefly. If you look at the ability to pump blood out of the leg, so in normal subjects, you can see this is the ejection fraction. So that's the ability to pump blood out of the leg. This is the percentage, this is the controls, the percentage that can be pumped out, and much lower in patients with venous disease. And then venous refilling, and this is in mils per second. So what this shows us is venous refilling is much faster in patients with venous disease because their valves are not functioning, whereas venous refilling is slower, and this is because it's coming from forward flow, whereas in patients with venous disease, it's reflux down those veins. And that reflux results in a higher pressure. And because they can't pump as much blood out of the leg, that also results in a higher pressure. So how does that actually go on and result in poor healing? Well, we know from various studies that patients with venous disease have tissue hypoxia, and there have been many studies looking at the blood flow in the legs of patients with venous disease and around venous leg ulcers, showing reduced laser Doppler flow, reduced transcutaneous oxygen measurements. The theories behind this is that there is some abnormality in the capillary bed. There may be more arteriovenous shunting of blood, so the blood doesn't get to the capillaries and get to the tissues. So it's quickly shunted around the capillary beds, which results in reduced microcirculation and reduced oxygen. It's also been thought that there may be a diffusion barrier to oxygen by, as in this slide, these are slides showing you fibrin deposited around a lot of the capillaries in the dermis. And that also is thought to impede the circulation or the nutrients going through the small vessels. And if you've got reduced flow in them and you have that, then obviously it leads to significant problems in the tissues. There's also been theories about white cells getting trapped in the dermal capillaries and reducing the blood flow through them. And to some extent, there's thoughts of a perfusion-reperfusion injury associated with that high blood pressure that also can result in some changes. So lots of understanding of what the ambulatory venous hypertension does to impede the microcirculation and the tissue perfusion in the legs of patients with venous ulcers. And the key things we can do here is compression therapy and exercise regimens. And compression therapy, as you'll all be aware, we have a number of options. The main option that we see is some form of multi-layer compression bandaging. There is a bit of debate about whether it should be elastic or inelastic, but essentially quite a few studies showing that they're both quite effective. There are some advantages or disadvantages to each one. We can use hook and fastener wrap systems like this. We can use stockings. But the long and the short of it is there's a lot of evidence that using compression improves the microcirculation, whether it's assessed by laser Doppler or transcutaneous oxygen. And so whichever method you use, it's beneficial in improving that microcirculation. This is just showing you what exercise does. And if you look at this, so you have the control subjects. This is before and after an exercise program. So this is just showing you the strength of the muscle. You can see how that's significantly improved. And similarly, in patients with venous disease, their strength is lower to begin with, and it improves almost to the level of what it is in those control subjects when you get them into a consistent exercise program. And this is just showing you how much it improves that ejection within the leg. So this is the controls. An exercise program improves that. But in patients with venous disease, it also significantly improves that, up to and a little bit beyond what we see in the control subjects. So we should not neglect exercise as a big part of how to improve circulation in patients with venous leg ulcers. So that gets us a long way in managing flow and circulation in patients with the common types of ulcers we see. But as we all know, there is sometimes difficulty with these patients. For example, patients with arterial disease, they may have exhausted all the reconstruction options. Or they may simply not have changes that are amenable to reconstruction. They may have other medical conditions that stop them having reconstruction, or they may simply have delays in their care. So, what we need and what is useful to us as clinicians is other ways beyond these traditional methods to help improve the microcirculation. Similarly, in patients with diabetic foot ulcers, some of them have difficulty using offloading, but some who use good offloading still have difficulty with getting the wounds to heal. And similarly with patients with venous ulcers, some are not able to use optimal compression, maybe because they can't tolerate the compression, but maybe because they've got some mixed disease. And some are really just simply not responding to that standard of care. And in all of these patients, we need other options to how to improve the microcirculation. But what this also does in many of these instances, it enables us to treat them further and keep them in their home and their community, without having to go to sometimes more invasive procedures, particularly if they're not suitable for those. So it gives us another option as to how we can adequately treat these patients and improve their microcirculation, which is the underlying problem that leads to their difficulties with their wounds healing. And the option that we have available to us these days is using the muscle pump activation device, or as you well know, it's the Gecko. What we do know is that it does improve arterial blood flow. There have been really a large number of studies now demonstrating the improvement in both arterial and venous blood flow, and also blood flow in the microcirculation. This is just doing a very brief summary of what studies have been out there looking at healthy subjects. And this is particularly looking at the femoral artery. You can see that increased blood flow. And with the use of laser Doppler flux either locally on the foot or using what's called laser speckle contrast imaging, shows increased perfusion in the foot. But the same now, as more studies have come out, is true of patients with arterial disease, venous disease, and patients with diabetes. So we do see that improved arterial flow in the femoral artery, and also the tibial arteries in a number of studies. We do see that improved laser Doppler flux in the foot. And we also see that improvement in laser speckle contrast imaging. This is just showing you laser speckle contrast imaging. So it's laser Doppler technology. This is showing you what happens in response to that normal pulsatile flow with the normal pulsation of the heart. So you get this increased flow with each pulse. But when you add the muscle pump activation device, this shows you get a much further improvement in microcirculation. So this is the site of a wound. You see that here, and then also in the tissues around the wound. And there have been a number of studies that have measured that increase in microcirculatory flux and also pulsatility. But what it's telling us is you're able to improve that microcirculation by using a device such as this, and that occurs as long as the patient's wearing the device. So certainly provides good opportunity, particularly over the course of part of the day, and often these are recommended for 12 hours a day. And in terms of healing ulcers, there is again emerging evidence that using this in these patients can actually help ulcers to heal. So there's one RCT in terms of venous leg ulcers that has demonstrated that with Keith Harding's group. There are a number of case studies, both in venous leg ulcers, diabetic foot ulcers, peripheral arterial ulcers, and there are some cohort studies as well that are sort of starting to demonstrate these improvements. We also know that there's reduced pain as well, particularly in patients with arterial disease. So part of that improving the microcirculation helps to improve the pain, which comes from that impaired microcirculation. So really, the use of the muscle pump activating device is another choice that we have as clinicians when patients are either not able to access care or the reconstruction care or appropriate care for offloading or appropriate compression for their venous leg ulcers, or for some reason they're not responding to those treatments, then this is another option for us. But this also particularly is an option we have, for patients, when they can't manage or can't access this care, but it helps us to give a treatment option for them so they can remain in the community. And if this will improve things sufficiently, then it can get them to the point, of being able to heal their wounds, reduce their pain, reduce their swelling. So I'm just going to finish with just a few case studies just to sort of demonstrate for you when we might think about using things like the muscle pump activating device. So this is a patient, a 91-year-old female patient. She had diabetes. She developed a blister after wearing new shoes, which is a very common cause of damage in the feet with patients with diabetes and neuropathy. She had a reduced ankle brachial index, so had some impairment of arterial blood supply. She also had a level of cellulitis and osteomyelitis, was treated with antibiotics, antimicrobial dressings, pressure offloading. This wound had not healed at 9 months. And so with further treatment, at this point, the muscle pump activating device was used. And over the course of the next couple of months, she saw a gradual reduction in this wound, and this had healed at approximately 2 months after implementing that. So what it's telling us is that this patient's wound had not responded to the normal things we would do, and you start to then almost despair at what you can do. But here you have a choice of something that can help it to improve and help it to heal, help to keep that patient in their home, to avoid other sort of major interventions that might need to be required if they had to go into hospital. Here's another patient, a 74-year-old patient, has peripheral arterial disease, has had a previous below-knee amputation on the left, recently had a femoropopliteal bypass graft on the right, which failed. So, unfortunately, sometimes with these bypasses, they do occlude. It may be short time after the operation. It can be months or even years. But once they fail, you often don't have too many other reconstruction options. And generally, they then have wounds that don't heal. They have pain. They have leg swelling. And so at this point, this patient was really potentially facing an amputation if things didn't improve. So the decision was made to use a muscle pump activating device. And over the next few weeks of treatment, you can see the wound improved. There started to be more granulation tissue in the wound. The pain settled, the swelling reduced. And obviously with continued use, the anticipation is this wound would heal, but it also took her from a situation of having severe rest pain and a potential amputation to having something that's now got potential to heal. And the final one is a patient with a venous leg ulcer, a 60-year-old male patient, had some diabetes but no arterial disease. He had his ulcer treated with standard compression therapy with antimicrobial dressings. But after 5 months of treatment, although only a relatively small ulcer, it still hadn't healed. Again, this patient was started on the muscle pump activating device, and over the ensuing few months, the wound started to initially clean up, and then ultimately, after about another 3 months, this wound had healed. So really, once again, this provides us with an option how to further improve the wounds in these patients to get them to go on and heal and avoid any other sort of major intervention, but also by reducing pain and discomfort, enable that patient to remain in their home and their community and to be functionally active. So with that, I will pause, and I'm very happy to take any questions at this stage.
Okay, thank you very much, Dr. Stacey. And we have a few questions that have come in. The first one is, in terms of offloading, what's the best option if the wound is on the lateral aspect of the foot or back of the heel, where total contact casting is not an option?
Yeah, yeah, no, thanks for that. That's a good question. And I think people sort of think there's some magic associated with total contact casting. I mean, total contact casting is basically, it's a way of putting something on that what it does more than anything is limits movement in the foot. But in addition to that, you can then have areas where you reduce the pressure by cutting out certain parts of that cast. But your next best option in patients who can't access it or can't tolerate it are things like using a Darko shoe that, and if you've got it on the heel, so there, I'm sorry, I didn't show the images there of the Darko shoes, but you have Darko shoes where there is effectively the heel part is cut out or the forefoot is cut out. So you've got less direct pressure on those areas. And then your other option is to use something like that Cam Walker, which is effectively a removable splint. And by doing that, that helps to reduce the pressure. The other thing with the Darko shoes is there are insoles that you can get. They're sometimes called a peg insole, where you can remove parts of the material within it. And by doing that, you can effectively remove that part of the insole that's directly over an ulcer. So you can reduce that direct pressure over the ulcer. So to answer the question, it depends whether your force is primarily direct pressure or shearing pressure. If it's direct pressure, you want to take that pressure off, so have something with an insole that takes the pressure off that area. If it's a shearing force, then you want to somehow stabilize the foot and the ankle, and that's where Cam Walker, removable splint, can do that for you.
Okay, thank you. So the next question is around who prescribes the muscle activating device?
Yeah, and no, thanks, and that's a good question. So the muscle activating device, I mean, in many cases where there is a multidisciplinary clinic or multidisciplines involved, oftentimes a physician will ask for it, will order it, but it doesn't have to be a physician. It can be, whoever's leading the care in that instance, whether it's a nurse in a nurse-led clinic or an NSWAC, but maybe Jeff Forney can answer that and sort of tell you from the sort of experience, how much comes from the physician, how much comes from the nurses in these sort of circumstances.
Yeah, it's absolutely not a prescription device. So, it can, in fact, a patient could order it on their own. And we have a sister product, which is used for muscle recovery by professional athletes, Olympians, elite athletes, et cetera. So the point being is that it's a benign device in terms of safety. So there's really not a need for prescription. And I'm getting a lot of questions I see in terms of access. And, regrettably, it was missed on the Ontario formulary, which is a lot of other products were missed as well. And so we're working to get that corrected. I see another question from BC. It is on the BC formulary. So, feel free to request it. It's available in all the health regions. And beyond that, I'm not sure what more I can add. We just need to, we need some work to do.
Right.
So the simple answer to the question, Kathy, is that, it can be ordered by any part of the treating team, and indeed the patients can access it themselves. So it's not a prescription item, as Jeff has indicated.
Right. And then you know, it looks like this is quite easy to use. And the question was, is this something an RN can apply? And based on what you've said, it sounds like an
Yeah.
RN can apply it.
Yeah, totally. And in fact, ultimately, it's the patients that apply it themselves or the patient's carers, because each device functions for, it's got a 24-hour, so 2-day cycle, so 12 hours each day. So they need to be replaced after that. So, you know, in most cases, the patients are able to do it or their caregivers are able to do it. But certainly a nurse, an RN or you know, nurse treating the patient can put it on and show them in the first instance. There's nothing complex about it. It's just about positioning it in the right spot and then just adjusting the intensity of the impulse that comes from it. And there's a very simple method of doing that on the device.
Okay. And Dr. Stacey, based on your experience when you use the muscle pump activating device, do you see a reduction in edema? And does it happen quickly or over time?
Yeah, no, good question. I mean, I've definitely seen a reduction in edema, and I think not just from my experience, but there are now some, you know, published studies that have actually demonstrated that in chronic wounds, also in other areas like patients who have renal transplants, have orthopedic surgery. There's good evidence that there is a reduction in swelling in those patients' legs. So absolutely there is, and maybe Jeff can speak some more for the evidence that he's aware of in terms of that.
Yeah, the only comment I'd make is, Michael, is that the renal transplant study actually fascinated me because we had no idea what to expect on that one. But we actually quantified edema in terms of urine output. And a urine meter is about the most precise method of measuring the reduction in edema. And we produced about 3 liters of additional urine over a 5-day period. So it's actually quite significant. And that applies to, and you think about that, that's a very transferable bit of data.
Excellent. And so there's another question that came in, and I'm going to attach it to a couple of things that I'm curious about as well. And it's about the wearability of the muscle pump activating device. Is it something you can wear when you walk around, or do you need to be laying or sitting when it's activated? Can you wear it when you're sleeping? Can you wear it when you're bathing?
Yeah, no, that's a really good question. So the short answer to a lot of that is you put it on and you leave it on. Now, the normal current recommendation is for patients to use it for 12 hours in the day. So when they get up in the morning, they leave it on, you know, till they leave it on, but just turn it off. So you can turn the actual impulse off on the device and then start it up again the next day. And it gives you 2 days of activity at 12 hours a day. Certainly can be used when you're walking, when you're sitting, when you're lying. The position doesn't really have any significant impact, still continues to walk. It doesn't interfere with people's walking. Washing, I think it's a fairly robust adhesive, but I don't know, Jeff might be able to tell you about what they recommend if people are washing.
Yeah, if the device actually it's a hydrogel. So if you want to take a shower, remove the device. Otherwise, it's just going to fall off in the shower.
Okay.
And in terms of sleep, whenever I travel to Europe, I pop these on and I sleep through the flight. And the first 20 minutes, it's weird because your muscles are contracting and you don't have control over it. So you notice every contraction. And I often use the analogy of if you've never breathed before, you started breathing, you'd notice every single breath. And with the Gecko device, it takes about 20 minutes and then becomes background. So it really for sleeping, it's really a non-issue over time.
Okay. And can this be used if a woman is pregnant?
Yeah, to my knowledge, there's no adverse effects associated with pregnancy. I mean, it's not having an impact on the pregnancy itself or anything systemically. It's primarily what it does. It just simply causes the muscles in the anterior and lateral compartments of the leg to contract, which is what one does with exercise. So it's not causing anything new or different to that. But Jeff, did you want to comment?
No, I'm trying to think if we have any regulatory requirement to address that. I don't think we do, but usually with any medical device, with pregnant women, you want to be absolutely careful.
Mhm. And what about patients that have congestive heart failure? Um,
Okay.
can they use it?
Well, actually, it's interesting. But Michael, why don't you, as a vascular surgeon, it might be best for you to come in, then I'll give you our background after that.
Yeah, yes. So, I mean, one of the challenges with people with congestive heart failure, is that is them being able to clear the fluid, from their bodies. And so, what ends up happening because of the impact of that function from the heart is the fluid tends to collect in the lower limbs. So this helps to mobilize that fluid to get it sort of into circulation to the kidneys and then get it expelled from the kidneys. So I'm not aware of any contraindication to using it. And I think there's also some studies that have indicated some improvements in cardiac function. Now, small studies, but maybe Jeff can comment more. He probably knows more of the detail on those.
Yeah, we have analyzed this in terms of ejection fraction, which is your big measure in congestive heart failure, right? And so we have a 5% increase in ejection fraction, which is in line with some of the best cardiac drugs. So the theory we have is that you increase your preload, reduce your afterload. So if you think about it, if you have a blocked river, we're getting rid of the blocked river and increasing the flow. The cardiac system is a closed system. So if you can add pumps to the system, it's going to improve outcomes. We do have a study designed. We haven't done it yet.
Okay. Is there any contraindication for this
None.
for the gecko?
None. Zero. It's an incredibly safe device. The only side effect that we've seen is actually a rash formation under the device. And if you think about it, the patients we're dealing with here in wound care all have vulnerable skin. And we're adding an adhesive to that skin and dumping a little bit of electricity through that skin over a period of time. The rash tends to form after about 3 to 4 weeks.
Mhm.
And if it does form, you can move the device and put in alternate locations.
Okay. And there's settings that are used for this device. How would you instruct the nurses to take a look at what setting to use?
Yeah, I can comment and maybe Jeff can give more detail, but basically, really all you're trying to do with this is just to increase or reduce the magnitude of the electrical impulse. And what you're looking for is two things. One is to see if they have muscle contraction. So you can increase it to the point of getting muscle contraction and ideally getting some movement at the ankle. So you can see a little twitch at the ankle. If it's too strong, you can reduce it. So you get it to a point of ideally seeing muscle contraction and a twitch and at a level that's comfortable. So it's really more adjusting it, individually to those patients. But Jeff, do you want to comment on it?
Yeah, we've actually analyzed that, and as soon as you see muscle contraction, there's a diminishing returns. So you can set it up to a point where the legs are going crazy, but you're really not getting a whole lot more out of it. But as soon as you start to see muscle contraction, you're pretty much at the optimal, and you need to balance the tolerance, versus what you're trying to achieve.
Okay. And Jeff, several times I've seen in the chat and the Q&A on the more practical side is where can people access the Gecko? Where can they buy it? Is it in pharmacies? Is it in home health stores? Where can they get it?
Yeah, it's actually we're too early for pharmacies and that type of availability. It's on formulary in parts of the country. The Ontario formulary, there's a lot of questions from Ontario, and I can sense frustration actually because regrettably it was missed on the formulary because there was a whole lot, but at any rate, I think anyone from Ontario knows what's going on. It's actually an election issue, and the CEO that was recently moved on was looking into how it got missed because it's unclear how it happened. But nevertheless, we believe that will get corrected, and we're working on that.
Okay, and is it available in the Yukon?
It's available, but we've never sold into the Yukon. So I think we've sold in Nunavut, but not into the Yukon.
Okay. Are there any contraindications with heart medication, or blood thinners or any other medication?
Absolutely none.
Okay. And the device says it only has a 30-hour battery life and is only used for 2 to 12-hour sessions. How many times do patients with wounds have to use the device? Or do we just keep replacing it? And if so, for how long? Is it until the wound is completely healed?
Yeah, often, unfortunately, Gecko is often brought in when it's very late and everything else has failed. We believe, like most things in medicine, if you catch it early, we can shorten the treatment time. But there's really no answer to that. But the bottom line is each device is good for 2 days. And we actually, it's interesting, we've done an analysis of the ecological impact of the device in terms of volume of garbage, weight of garbage. The Gecko device is 100% recyclable. So you think about all the dressings. We cut healing time in half in venous leg ulcers. So you think about all of the biohazardous waste that goes that's a result of treating a venous leg ulcer, and we cut it in half because our device is 100% recyclable, so it's not ending up in a landfill.
Okay, well, thank you very much. So that brings us to the end of the webinar. And Dr. Stacey, we'd like to thank you for bringing us such great information on microcirculation and improving blood flow. And Jeff, thank you so much for giving more information on the Gecko. And we hope that everyone enjoyed the webinar and are taking some key learning points back to their clinical practice. And we look forward to having all of you at the next webinar in this 6-part series. So just go to nswalk.ca, the website, and click on webinars, and you'll be able to see when all of the webinar series are happening. So again, thank you to Jeff Forney and Perfuse MedTech and Dr. Stacey and the Canadian Home Care Association for partnering. Thank you very much.
Thanks very much, Kathy, and thanks for the opportunity to present to this group. And thanks all of you for giving up your time to come and listen to this. Really appreciate it.
Yep. Yeah, thank you. Have a good night.